first, we will be discussing adrenergics, and then probably next meeting yung all about cholinergics, yung mga drugs that targets parasympathetic system. Sa adrenergics, i-discuss natin yung two classifications of drugs, yung mga agonists, and then also the antagonists. So when we say agonists, again, this is the term that implies to activating the adrenergic receptors. Okay, so lahat ng naaral natin last meeting regarding adrenergic receptor activation, agonists nga drugs, they will support those effects, those responses. Okay? Then kabaliktaran naman yung antagonist. They will counteract the effects related to activating the adrenergic receptors. Okay? Yung mga agonist, they are also known as sympathomimetics. Again, yung mga adrenergic agonists, tawag din sa kanila sympathomimetics, meaning to say, they mimic, meaning kinokopya nila yung yung mismong effect ng mga natural norepinephrines. Diba? Norepinephrine mismo, yung natural neurotransmitter that binds to sympathetic receptors para enhance yung sympathetic transmission, yung sympathetic effect. Okay? So, yung mga gamot na classified under this umbrella, nga adrenergic agonist sila, gagayahin lang nila no, yung mga effect ng natural norepinephrine. Okay? So, again, generally speaking, they enhances the sympathetic effect, yung mismong sympathetic outflow. Okay? Kaya nga agonist sila. Okay? Sige. Now, when we say sympathomimetics, we can classify them into two ways. So, meron tayong dalawang ways to classify them. Pwedeng based on structure. So, yan yung based on chemistry. Or based on MOA, based on their mechanism of action. Again, under adrenergic agonist pwede natin silang mag-classify based on structure and based on MOA. Under chemistry, we have two sub-classification. We have catecholamines, meron ding non-catecholamines. Then under MOA, we have three sub-classifications: direct acting, indirect acting, and also mixed acting one. So we will be discussing each one of these sub-classifications later ng mga slides. Okay, so at this juncture, let us begin discussing the classification of adrenergic agonists in terms of chemistry. So again, kapag in terms of chemistry, it has something to do with the structure ng mismong gamot. Or we are referring here to the classification of the drug based on SAR. Diba? Sa inyuhang org meds, this is the focus kapag medicinal organic chemistry yung pinag-uusapan. We relate the structure, the chemistry of the drug to its action. Kasi meron talaga yung kinalaman. No? Yung MOA ng mga gamot, may kinalaman yan sa structure. Whatever is being observed sa structure ng gamot. Okay, so what are the classifications of adrenergic agonists in terms of chemistry? So we have two again. Number one, we have catecholamines, and then we also have non-catecholamines. Okay, so we will differentiate the two. Again, ito ay base sa structure, kung ano mismong nakikita na structure sa adrenergic agonist. So we'll start with catecholamines. So we can understand the term itself by segmenting, no? We segment the term into two. We have the catechol, nga term, and then we have amine. So if you try to read, diba, the term, it has something to do with the structure. Catechol, it's a structure, organic structure. Also, amine, it's a structure, no? Ang catechol class, yung structure niya, it is actually also chemically known as dihydroxybenzene. Dihydroxybenzene. So meaning, it's a cyclic ring. Okay, so meron siyang cyclic ring, okay, in a form of benzene ring. So ayan. And as we read its chemical name, meron siyang dalawang hydroxyl group. Kaya nga, dihydroxy. Now, yung dalawang hydroxy present sa catechol nga ring, meron itong importance when it comes to its position, no, of its hydroxy. Particularly, yung dalawang hydroxy sa benzene ring dito is in ortho position. Okay, again, yung dalawang OH sa benzene ring is in ortho position. I know you are familiar, no, with this prefix pertaining to position. Yes, correct. Ang positioning dito kapag ortho, it's 1, 2, ibig sabihin, adjacent. Okay, so OH, ayan, magkatabi, kumbaga, yung dalawang OH. So, yan yung catechol. Again, based sa kanyang structure, since it contains hydroxyl, because of the presence of that hydroxyl, then we could tell na highly polar yung portion na yan, yung mga may OH, diba? Kapag may electronegative atom present, that makes it a polar group. Okay, so again, polar yung catechol generally. Next, let's have the amine portion. Particularly, yung amine dyan is in a form of ethyl amine. So kapag ethyl amine, ethyl, it implies 2 carbon. Okay, in that amine structure, ethyl amine. Okay, so whenever you heard about catechol amine, so dapat meron siyang ganitong structure, which is the catechol, and dapat merong ethyl amine. If may absence of either of the two or both, then we don't consider that as catechol amine already. Okay, kaya yung first bullet, sabi dyan, 3,4 dihydroxybenzene group. Okay, so yan yung catechol specifically being described based sa kanyang chemical name or systematic name. Okay, sige. Now, with regards to its structure, this time, i-relate naman natin yung structure niya to its characteristics or properties based sa mga nakasulat sa mga remaining bullets. Okay? So, let's have the second bullet. Sabi dito, ang mga catechol amines, they are high potency, they have high potency in activating alpha and beta receptors. Meaning, meron silang affinity to alpha receptors and also beta receptors. And sabi dito, highly potent sila. Ibig sabihin, di ba pag potent, it only requires low concentration or low dose for it to produce an effect. Okay? Kaya nakalagay dyan, highly potent sila. Konti lang na dose concentration, they are powerful enough to activate already alpha and beta receptors. Okay? Sige. Let's have the third bullet. Also, ang mga catecholamines, they are being metabolized, highly metabolized by the following enzymes: monoamine oxidase and also the catechol O-methyltransferase or the COMT. Again, these are the degradation ng mga degrading ng mga enzyme na ga-metabolize sa catecholamines. Okay? Now, with regards to their locations in our bodily system, ang mga monoamine oxidase or MAO, they are highly concentrated presynaptically. Susulat nyo, highly concentrated sila presynaptically, meaning sa vasomotor center, no, sa CNS particularly. Whereas, yung mga COMT naman, these degrading enzymes, they are more concentrated naman sa liver. Okay? So again, these are the two degrading enzymes ha, nga ga-metabolize sa catecholamines and highly prone talaga no yung catecholamines to these enzymes. Now focusing on one of the enzyme nga ga-degrade sa catecholamines, the COMT, sabi dito, diba, they are concentrated in the liver. Because of this, nga ang COMT highly concentrated sila sa liver, may mataas na chance, no? Mataas na chance nga ang catecholamines kapag tinake siya orally, no, administered siya orally, it will really undergo extensive first pass effect. Okay? Yes, correct. Or that we call it FPE or first pass metabolism. Okay, so yan, characteristic yan ng catecholamines kapag na-administer sila no orally. Kaya never will happen no sa mga catecholamines available commercially in the market na tinitake sila orally. Hindi po sila tinitake orally kasi again, highly prone sila no to first pass effect. Actually, 'di ba kapag orally taken ng mga gamot, usually basta orally taken, muagi man gyud na sila og first pass effect. Although hindi lahat, but majority kapag orally taken prior to reaching the systemic circulation according to pharmacokinetics, di ba? Pag orally taken, muagi sila sa liver. They are being prematurely metabolized in the liver before sila maka-reach sa systemic circulation for absorption. Kaya nga, pag orally taken, lesser ang bioavailability kumpara 'di ba sa mga parenterally given or administered na mga gamot. Talagang 100% bioavailable kapag parenterally administered yung gamot. So with regards to catecholamines, take note ha, they are not orally administered. So take note of that. Now with this characteristic ng catecholamines, highly metabolized sila by MAO and also COMT, they will now exhibit short duration of action sa katawan. Panandalian lang, kumbaga. Hindi sila pangmatagalan, hindi sila longer nagsistay sa katawan. So shorter yung duration nila kasi nga, they are highly metabolized. And another characteristic ng catecholamines, they do not penetrate in the CNS. So it has something to do actually with the nature ng blood-brain barrier. Yung blood-brain barrier kasi natin, di ba, highly lipophilic siya. So they love non-polar lang na mga compounds for it to be penetrated sa CNS, knowing like dissolves like. Ang BBB, highly lipophilic siya. Ano sabi natin sa catecholamines? It is polar. Very good. Okay, so sulat nyo dyan, polar ang catecholamines. So they do not penetrate CNS. Okay. Now, with regards to the administration, baka makalimutan kong isulat, no? Since not orally administered sila, kindly take note, syempre, parenterally given sila. Usually, given IV, diba, parenteral yan, or subcutaneous, or pwede din naman, in some cases lang naman, inhalation. Okay? So, yan yung mga characteristics, properties ng mga catecholamines. Okay, so may relationship ito sa kanilang structure. Now, let's proceed to the second classification of adrenergic agonists. In terms of structure pa to ha, or chemistry, we have non-catecholamines naman. So, yung non-catecholamines is actually yung kumbaga yung property nila actually opposite sa mga na mention natin dito sa left side, no? Na mga written nga mga property sa left side, opposite naman yung property nila for non-catecholamines. Okay, kasi pag non-catecholamines, walang catechol or walang ethyl amines sa structure. Okay, so kaya nakasulat dito, sabi, yung characteristic ng non-catecholamines, they are not metabolized by MAO or COMT. Kasi wala naman silang catechol. Diba? So they are not good substrates ng MAO or COMT na enzyme. Okay, so with that, kung hindi sila prone to metabolism by MAO and COMT, they will have longer half-lives, longer yung duration of action nila. Hanggang tumatagal sila, no, sa katawan. And then, therefore, they can be administered orally. Kasi nga, hindi naman sila na-metabolize, diba? Not metabolized by COMT. So, pwede sila ma-administered orally. Okay, what about their penetration to CNS? Do you think they can penetrate to CNS? Yes or no? Okay, yes. So, opposite lang ha ng catecholamines. Sige. Now, with regards to the examples ng catecholamines, we have the following. We have dopamine, epinephrine, isoproterenol, or epinephrine. So, pag ganito na mga pangalan na ng gamot, it's already your job no, to memorize them. Okay? Sige. So, with regards to what I am highlighting, ito yung mga tinatawag natin na natural catecholamines. Kumbaga, yung katawan natin is capable of producing these natural compounds or the natural catecholamines, dopamine, epinephrine at saka norepinephrine. Di ba ato ni silang na-classify as a neurotransmitter for sympathetic na nervous system. Although meron din tayong synthetic one na ay kanang man-made, artificially made in the laboratory, but what I am pointing here is yung kaya ng katawan natin i-produce ito sila. Si dopamine, epinephrine, and norepi. Okay, now based sa structure, I know we could agree, no? All of us could agree na kung titingnan natin yung structure, they are really catecholamine. May catechol, tingnan ha, yung structure, may catechol, at saka merong ethylamine, specifically ethylamine. Okay, so I am confident na kung naay assessment na related to identification of adrenergic agonist based on structure, madali nyo siyang ma-answer. Okay, kasi you will just look for the presence of a catechol group and also the ethylamine group. Dapat sila giduha ha, present. Kung absent ang usa, dili na siya catecholamine. Samot kung absent ang duha, ang catechol at saka yung ethylamine. Okay, let's proceed to non-catecholamine na mga halimbawa. We have phenylephrine, methoxamine, ephedrine, and amphetamine. So based sa structure ulit, kung titingnan natin, 'di ba, wala silang catechols. Okay, so they are truly, evidently, no, non-catecholamines. Okay, so yan yung first classification ng mga sympathomimetics based on chemistry. So we're done with the first classification. So this time, i-discuss naman natin yung classification ng sympathomimetics based on MOA. mechanism of action nila. Okay, so again, meron tayong three sub-classifications, di ba? Based sa introductory slide kanina. We have direct acting, indirect acting, and also mixed acting. Okay, so under direct acting, ida-discuss natin individually yung mga sub-classifications rather. We have the endogenous catecholamines under direct acting, also the alpha and beta agonists. So under yan sila sa direct acting. Then we have indirect acting, the releasers and the reuptake inhibitors. Pag mixed acting na, so combination ng dalawang na-mention. Meron silang both direct acting and indirect acting na property. Okay? Now with regards to endogenous, so iba kapag endogenous, it is synthesized within sa body. So ito yung mga natural catecholamines din. And natural catecholamines are classified as non-selective. Okay? Non-selective sila ng mga direct acting. Whereas, ang mga alpha agonist and also beta agonist, sila naman ay classified specifically as selective direct acting. So later, I will give overview what does these terms mean. Okay? Sige. So for this slide naman, ayan. Okay, I will give an overview. What does the three general classifications based on MOA mean? Ano ibig sabihin ng direct acting, indirect acting, at saka mixed acting? Kapag sinabing, let's have first, direct acting. Ayan. Pag sinabing direct acting, it has something to do with a drug that directly activates the receptor. So, kumbaga, you have a drug, and for it to produce an effect, it will cause a receptor activation. Kumbaga, ang drug mismo, you have a drug, yung drug mismo ang magbabind directly sa receptor. That's why it is direct acting. Okay, again, ang drug mismo ang magbabind sa receptor, causing activation, stimulation of that receptor. Okay, next, with regards to indirect acting, sabi dito, you have a drug and the drug will enhance release of norepinephrine from vesicles. Okay, so kumbaga, sa indirect acting, yes, it will also enhance the sympathetic outflow na e-induce niya yung sympathetic effect. But this time, hindi yung gamot yung directly magbabind no, sa receptor. Ang gagawin niya, na e-enhance niya yung sympathetic outflow because it will cause enhancement of release ng mga natural norepinephrine specifically. Okay, so you have a drug, ang gagawin lang ng gamot, iyahang i-trigger ang release ng principal neurotransmitter ng sympathetic system. Diba? That is norepinephrine. So kung marami na yung norepinephrine, that will now be available for binding. Okay, so pag may presence ng indirect acting na gamot, pinapataas niya lalo, kumbaga, than the normal na release, no? Ng norepinephrine, pinapa-enhance niya lalo yung level ng natural norepinephrine. Okay? Kanina, dito sa direct acting, di ba, ang drug mismo yung kakabit sa receptor. And then gagayahin niya kung ano man yung effect ng isang natural norepinephrine. Imimimic niya yon. Okay? Sige. Now, with regards to indirect acting na mechanism, pwedeng there are different ways, no? Paano ang isang indirect acting mag-enhance ng norepinephrine levels from the vesicle. So pwedeng, una, we have indirect acting drugs that will target enhancement of exocytosis. So we have drugs na yung gagawin nila indirectly, ilang ipa-enhance ang release ng norepi. Di ba naalala, exocytosis, that's the phenomena kung paano na-release ang norepinephrine from the presynapse. Okay? Now, if you understand exocytosis, enhancing exocytosis, you could relate that to enhancing level of natural norepinephrine, di ba? With this mechanism, talagang ang end result na enhance niya yung availability ng norepinephrine available for binding. Okay? The other mechanism ng mga indirect acting drugs, pwedeng via reuptake inhibition. Reuptake process inhibition. Or sila yung mga gamot na tinatawag na reuptake inhibitors. So I know you have learned about reuptake process. Diba? Ito yung major nga termination ng norepinephrine sa cleft. Okay, once it is available in the cleft, ang reuptake itself. Ang nangyayari sa reuptake na a-uptaken or ibabalik natin yung norepinephrine dito sa presynapse. It will be stored again via the net, di ba? We have that, naalala yung net na transporter. Yan yung passage transporter ngayon ng mga norepinephrine para ito'y maibalik sa presynapse. So yung gagawin ng mga indirect acting sympathomimetics, pwede din via reuptake inhibition. Pipigilan nila or ibablock nila yung net, yung reuptake process, thus enhancing the level of norepinephrine in the cleft. So there will be more available norepinephrine para makapag-bind sila doon sa postsynaptic receptors. Okay? So pag may dagdag na inhibition, di ba? Inhibition, ang net result dyan, napapataas yung norepinephrine. Okay, are you following? Can you show a thumbs up if you understand the reuptake inhibition nga process? Okay, that's good. Then we have the last general classification based on MOA. We have mixed acting. Kapag mixed acting, meron siyang, ang drug mismo, meron siyang both direct acting na mechanism, pwede din siya mag-act indirectly. Okay? So kung direct, siya mismo yung kakabit sa receptor and then producing an effect. Indirect, particularly for mixed acting, yung associated sa kanya na indirect acting mechanism is being a releaser. Yung napapa-enhance niya yung exocytosis. Kapag releaser it has something to do with exocytosis. Okay, releaser sila ng norepi. So yan yung, kumbaga, majority sa indirect acting ng mga mixed acting sympathomimetics. Okay, so that's the overview about the three general classifications ng sympathomimetics. So this time, we will be discussing the sub-classifications per general class ng sympathomimetics. So uunahin natin yung mga direct acting. Again, we have the natural catecholamines and then alpha beta agonist. Okay? So with regards to direct acting adrenergic agonist, di ba pwede natin sila ma-classify again based on selectivity. Yun yung sinulat ko kanina. May mga non-selective, meron din selective. Ito ay based sa kaartehan. Okay? Kaartehan nila to bind sa receptor. So we have Direct acting adrenergic agonist nga non-selective. Okay? So hindi sila maarte when it comes to binding to adrenergic receptors. Meaning to say, they could bind to more than one general type na receptor. Okay? General type na receptor. Pwedeng they could bind to alpha and beta receptor. So both alpha and beta, or pwede din uh, kasama dopaminergic receptor. Okay, so again, magiging non-selective siya if kaya niyang mag-bind to more than one general type of receptor. Pwedeng alpha, beta, or lahat yan ng mga adrenergic or sympathetic receptors. Now, what if nag-bind lang siya sa isang alpha receptor, may it be alpha 1 or alpha 2, that's the time yung direct acting selectivity niya, it can be classified as being a selective na direct acting. Okay? Kumbaga, they only bind to one general type of receptor. So, pwedeng mag-bind lang siya sa isang alpha, either or both, alpha 1 and alpha 2, as long as one general type nga receptor. Kung ang iyahang ginabind, beta 1, beta 2, biskan pag duha na ka subtype ni beta 2, pero usa ra man na ka general receptor, beta ra man na sila. So, selective pa rin yan siya. Okay? Sige. So, those are the sub-classifications based on selectivity ng mga direct acting sympathomimetics. So, let's enumerate what are those direct acting, starting with the non-selective nga mga direct acting. So, we have the natural catecholamines. Okay? Natural catecholamines or the endogenous catecholamines. Non-selective sila. So let's find out here, bakit sila non-selective? Ano yung mga receptor specifically that they bind to? Okay? So again, we have epinephrine, norepinephrine, and dopamine. So with regards to epinephrine, or this is synonymous to adrenaline, it has actually affinity to the following adrenergic receptor. It has affinity to beta 1, beta 2, and also alpha 1 receptor. So, di ba? You have a beta and alpha receptor. Yun yung affinity ng epinephrine. It is able to activate these specific types ng adrenergic receptor. And kindly take note, wala siyang effect to alpha 2. Okay, so that's for epinephrine. And then for norepinephrine naman, or this is also synonymous to noradrenaline or levarterenol, take note, yung affinity niya, it is able to cause receptor activation ng alpha 1 and also beta 1. Okay? So no effect at all. Kindly take note, wala siyang significant effect. Yung significant talaga yung may beneficial effect to beta 2. Okay? Kindly take note, no significant effect on beta 2. That's for norepinephrine. And then for dopamine, kindly take note, meron siyang affinity to dopamine 1 and 2 followed by beta 1 and alpha 1. Okay? So, in short, if you try to analyze bakit sila non-selective, it actually reflects to their receptor affinity. They are able to activate more than one general type of adrenergic receptor. Now, based sa information dito, we could somehow connect this to clinical relevance nila, no? Kapag tinanong kayo, based sa tanawa ang ilang mga receptor affinity, base dyan sa information na yan, which do you think could be beneficial as bronchodilator? Among the three natural catecholamines, which do you think is useful, clinically useful as bronchodilator? Very good. It's epinephrine. Base sa information na to. Because it has affinity to beta 2 receptor. As we recall, ang beta 2, it is concentrated, dislocated in the bronchial smooth muscle, and activation of that beta 2 in the bronchioles will cause bronchodilation. Walang iba, di ba? Walang ibang natural catecholamine dito aside from epinephrine na kayang mag-activate sa beta 2. Only epinephrine. Okay, take note of the difference. That's how you study no affinities. Kung asa sila nag-differ, asa sila merong similarity. Kung similarity naman, anong klaseng receptor common sa tatlo? Anong receptor na ina-activate nila common sa tatlo? Very good. It's beta 1. Tingnan, may beta 1 for epinephrine, beta 1 agonist din si norepi, ganun din si dopamine. So ano yung clinical relevance kung kaya nilang i-activate yung beta 1? Ibig sabihin, these are cardiac stimulant ng mga gamot. Kasi meron silang affinity to beta 1. Kapag na-activate ang beta 1 sa heart, di ba? Increase inotropy, chronotropy, dromotropy. So cardiac stimulant yung tatlo. Okay? So that's how you study them. Also, meron din silang affinity no to alpha 1. So they are somehow vasoconstrictors ng mga gamot. So we have actually a separate segment na i-discuss no yung clinical relevance ng mga natural catecholamines. Okay? Sige. Now for this slide, paki-correct no. 'Di ba ang alpha at saka beta agonist, they are already selective nga direct acting. So kung selective direct acting sila, kapag ang gamot classified as alpha agonist, it will only bind, activate alpha receptor. Kapag beta agonist yan, so it will selectively bind to beta receptors lang. Yun lang ibig sabihin ng selective sila nga direct acting. Okay, maarte sila when it comes to binding. Meron lang specific nga receptor sila, kung saan sila nagbabind. Okay, so again, alpha and beta agonists are selective direct acting. Now for this table, I was able to introduce this already when we discuss about receptor activity, so yung receptor activation, receptor effects. Sige, let's run through. I-run through lang nato. Although you have understand this already, di ba? Halimbawa, with regards to alpha 1, yung locations niya or yung mga effector organs sa katawan na may alpha 1, naalala yung radial smooth muscle, meron din sa sphincter ng urinary bladder, pilomotor, diba? Smooth muscle. Ito medyo hindi ko lang, kindly add na lang this information, hindi ko siya na-mention, no? Last meeting, kindly add, this has also something to do with alpha 1 activation, ejaculation for seminal vesicle smooth muscle. Okay, then for alpha 2 presynaptic, particularly presynaptic, diba, this is GI link nga receptor. Kung ang alpha 1 GQ, ang atong guiding principle is contraction. For alpha 2 presynaptic GI, auto-regulation. Okay, auto-regulation. So, ayan. May mga alpha 2 presynaptically, majority of them, diba, presynaptically located. So, ayan, there will be inhibition of norepinephrine. For beta receptor nga activation, beta 1 meron sa heart, also located in the kidney. Naalala yon? Kapag na-stimulate yung beta 1 sa heart, increased heart rate, contractility, and even conduction velocity. Kapag na-stimulate yung beta 1 naman sa kidney, ano yung end result? Kapag na-release yung renin doon sa juxtaglomerular cell, increase yung BP. So ito lang din yung na-discuss natin ha. Last meeting, naka-table lang siya. Then for beta 2, nga marami, di ba? Maraming effector organs kung saan natin malolocate yung mga beta 2 receptor. Sa vascular smooth muscle, ito yung blood vessel na nagsusupply ng blood sa skeletal muscle. Diba? Relax, so vasodilation. Sa bronchial smooth muscle, diba? Bronchodilation. So yung sa uterine smooth muscle, ito yung tocolysis. Okay, sa skeletal muscle membrane, naalala yung uptake of potassium ion. Ano yung end result sa blood, diba? Hypokalemia. Diba? Kapag na-activate yung beta 2 sa skeletal muscle cell membrane. Okay, then beta 3. Na-discuss ko din to, di ba? It is located in the adipose tissue. And then kapag na-activate yung beta 3, lipolysis. Treatment ito for, pwede siya, clinically useful siya for obesity. Okay? So this were already discussed sa previous meeting natin. So with that, yung foundation nyo doon on receptor effects, that will be your, kumbaga, magiging guide nyo para dali na lang ma-appreciate yung MOA, mechanism of action ng mga gamot. Kasi kapag agonist nga ang isang gamot, they will just support all these effects. Kapag agonist ng beta receptor ang isang gamot, they will support these effects. Kapag agonist ng alpha receptor, they will activate or also support these effects. Okay, sige, let's have the selective alpha receptor agonist. What are the examples, no, by name? Alpha 1 selective direct acting agonists specifically are the following. We have phenylephrine, methoxamine, medodrine, propihexidrine, tetrahydrozoline, nefazoline. Again, kung alpha 1 selective sila, they activate alpha 1 receptor. So, unsa man to inyong mga nadumduman nga alpha 1 receptor activation? Do you agree nga vasoconstrictor ito sila? Yes or no? Vasoconstrictor ba yung mga gamot na to being an alpha 1 direct acting agonist? Yes or no? Or naglag ang akong chat box? Again, let me repeat the question. Since if they are classified as alpha 1 direct acting agonist, will you consider them as vasoconstrictors nga mga gamot? Yes or no? Okay. Yes. Because we all know nga ang alpha 1, they are located, di ba, sa blood vessels. Activation of alpha 1 in the blood vessels will cause constriction or vasoconstriction. So lahat ng mga alpha 1 agonists are also classified as vasoconstrictors. Next. We also have alpha 2 selective ng mga direct acting agonists. We have the following: clonidine, methyldopa, guanfacine, guanabens. Particularly yung first four, they activate the presynaptic alpha 2 receptor. Okay, they activate, agonist sila, no, ng presynaptic alpha 2. Whereas yung remaining two, apraclonidine, brimonidine, they are able to activate naman the postsynaptic alpha-2. Okay? So these are examples of alpha-2 agonists, presynaptically acting and those postsynaptically acting. Kapag ano ha, pangalan na ng gamot, your turn na yan. Your turn to memorize them. Next. So done with alpha 1 and alpha 2. So what are examples naman of beta agonists? So we actually have non-selective nga beta agonist. Okay? Bakit non-selective yung nakalagay, ma'am? Tapos beta receptor ang mangkahaiyahang gina-activate. So it should be selective. Yes, being a direct acting ha nga yung umbrella direct acting yung pinag-uusapan, then we consider it as selective direct acting nga sympathomimetics. Kasi nga one general type of receptor yung kaya niyang i-activate. Only beta receptor. What makes it non-selective here? Non-selective because it could specifically activate beta 1 and also beta 2. Dito ko nang isulat, beta 1 and also beta 2. That makes it non-selective here. Being a beta agonist, being a beta stimulator, non-selective siya kasi pwede siyang mag-bind sa beta 1, beta 2. But being a direct acting nga agonist, no? Being a direct acting sympathomimetics, generally selective siya. Okay, I hope you understand no the terms kanina para hindi kayo ma-confuse. Okay? So example, specific example ng beta non-selective direct acting, we have isoproterenol or this is also known as isoprenaline. Okay? Then we also have beta 1 selective na direct acting. So kung beta 1 selective direct acting siya, it only activate no beta 1 receptor. So isa siyang cardiac acting nga gamot. Kasi beta 1 man ang iyahang gi-activate. So we have one specific example, we have dobutamine. Okay. Then we also have beta 2 selective na mga direct acting. So we have the following. Albuterol, also known as salbutamol, metaproterenol, terbutalin, perbuterol, salmeterol, formoterol, indacaterol, so on and so forth. Yung unang apat sa listahan, we could classify them as SABAs, short-acting nga mga beta agonist, beta 2 agonist. Okay, short-acting sila. Whereas yung salmeterol, formoterol, indacaterol, and kindly add also yung bambuterol. Bambuterol, kindly add. These are labas naman. Kapag labas, long-acting. Okay, long-acting nga beta agonists. Okay? So, I know you're familiar no, with these drugs, lalo na yung salbutamol. It is actually also known as albuterol. Para saan ba sila? Diba? They are clinically relevant, beneficial to those patients na may bronchospasm, may asthma, may COPD kasi nga they can be used as bronchodilators. Very good. Bronchodilators yan sila. So kindly take note of the subclassification ha based on their duration of action. May short-acting, mayroong long-acting. Okay. Another, we also have beta 2 agonists na instead of their bronchodilating effect, or aside no from bronchodilating effect, meron din tayong beta 2 agonist na ginagamit as tocolytics. Yung mga tocolytics, they also fall under beta 2 receptor activation. Okay, so yung mga tocolytics halimbawa, yung ritodrin, and also isoxaprine. Kindly add here sa slide. Beta 2 agonist din yan sila. Kaya lang, ang gamit nila, tocolytics. Ano ibig sabihin ng tocolytics? They relax uterine smooth muscle. Yung ginagamit para maiwasan yung premature labor. Okay, tocolytics, relaxation of uterine smooth muscle. So you have ritodrin, isoxaprine. Okay, so memorize niyo yan. Wala mo choice, no? Memorize din niyo ang pangalan sa mga gamot. So those are beta 2 agonists. Non-selective, then we have beta 1 and beta 2. Then under dopaminergic nga receptor agonists, we only have one. So okay ra. So isa ra ang dopamine agonist. Specifically, it activates dopamine 1 receptor. So yung effect naman niya, it is able to dilate renal blood vessels. So with that, kung kaya niyang i-dilate yung renal blood vessels, or it causes, di ba, renal vasodilation. So because of that effect, it could potentially enhance the glomerular filtration rate. So kung enhance yung glomerular filtration rate, therefore enhancing diuresis. So yan yung effect ng dopamine 1 agonist. So a good example is yung phenoldopam. Okay, so yan yung isa na pinaka-common example ng dopamine 1 agonist. So kindly take note of its effect. Okay, sige. So done with direct acting. So this time, sige, para di mo mawala. So we were able to mention, no, ano yung mga halimbawa ng mga direct acting selective agonists. We have the alpha receptor agonist, and dito beta receptor agonist, and then dopamine agonist. So done with direct acting. Next, we have indirect acting adrenergic agonist. So ano yung ibig sabihin ulit ng indirect acting? This time, they could exhibit, no, the effect as releasers. They enhance, no, the release of norepinephrine. They enhance the exocytosis, or pwede din naman they inhibit the reuptake. Very good. They reuptake, they inhibit reuptake. Inhibitors. Okay, yun yung mga indirect acting. Okay? So in this slide, particularly, sila yung mga releasers specifically. So kung releasers sila, classified as releasers, enhance nila ang exocytosis. Enhance sila sa release ng norepinephrine. So we have the following example. Memorize gapon eh. Amphetamine, methamphetamine, tyramine, phenmetrazine, methylphenidate, modafinil. Okay? Yung na-mention ko na yung iba dito. No, I think asa to siya nga slide. Katong nag-discuss ta about sympathetic adrenergic neurotransmission. Yung nag-discuss ako ng pro-sympathetic drugs, anti-sympathetic drugs. Naalala yung mnemonics nga T? Muna sila. Yung tyramine, ephedrine. Ephedrine is also a releaser. But there's actually a rationale or a reason bakit hindi siya nakasulat dito. So mamaya nga slide, may ephedrine mamaya. Amphetamine, di ba? Three A's means amphetamine. Okay, kaya nakalagay dyan. So, you can make use of this mnemonics, then just add the rest na hindi nakasulat. Okay? So, yan yung releasers and yung reuptake inhibitors, ito yon. Okay? So, cocaine, atomoxetine, reboxetine, sibutramine. Okay? So, yan yung reuptake inhibitor. So, they fall under indirect acting. Pag ganito ng mga slides, memorize lang na siya. Yung sa clinical uses, meron tayong separate slide doon, yung clinical applications nila. Okay, sige, proceed. Ano naman yung mga halimbawa ng mixed acting adrenergic agonists? So ito, they both have, di ba, direct and indirect acting. Pwedeng sila mismo yung mag-bind sa receptor or they will simply act as releasers. Kasi 'di ba yung sabi ko kanina, ang ilang indirect acting mechanism is as releaser. Okay? So ito 'yon, si ephedrine pala, it is classified as mixed acting. Okay? So aside from being a releaser, nagre-release, nag-enhance ng release ng norepinephrine, it could also bind sa mismong receptor, activating that adrenergic receptor. And kindly add, we have pseudoephedrine, methentermine, phenylpropanolamine. Okay? Yung ephedrine, this is actually associated with cardiovascular symptoms. Okay, so meron siyang kaakibat no nga mga adverse effects related to cardiovascular. So we could classify or we could conclude no nga deadly siya, nakakamatay siya. Because if the drug has adverse effects nga something to do with cardiovascular, life-threatening na siya nga mga gamot. Okay? Ang pseudoephedrine, this is a precursor in shabu synthesis. Ginagamit siya no, as precursor, raw material in making or synthesizing shabu. Okay, yung shabu, yan yung methamphetamine. Yan din yun, yung na-mention ko earlier. Ito din yun, yung shabu. Parehas na siya. Chemical name niya, methamphetamine. Okay, so those are the drugs, no? Drug classification nila and ano yung mga example under sympathomimetics. So again, we have the natural nga catecholamines and the alpha beta agonists. They fall under direct acting. We also have indirect acting. And then finally, ito, mixed acting. So with those slides presented, more on memorization of the names of drugs. Pag ganoon, you need to memorize na the drugs, ha? Dito naman, clinical uses. Ano yung clinical relevance ng mga na-mention natin na mga gamot? Okay? Again, ang adrenergic agonists, particularly na clinical uses. Kasi hindi nasulat dito, no? Focusing on sympathomimetics ito. Sympathomimetics. Kasi pag sinabi mong adrenergic drugs, pwede yung agonist, pwedeng antagonist. Yung focus muna natin are the clinical relevance of those agonists. Agonist ng adrenergic receptor. So we'll start, ganun pa rin yung pattern. We'll start with direct acting. Diba? Under direct acting, ang catecholamines at saka yung alpha-beta agonist. Okay, musunod dayon ang indirect acting. Then, last, mixed acting. So dito naman ha, mga clinical relevance yung focus nila. Ano yung clinical indications nila, clinical applications. Okay, so we'll have endogenous catecholamines first, or the natural catecholamines. So epinephrine, it says here, it is the first line in, or it is the first line na cardiac stimulant. Okay, so this is just reflective to its receptor activation. 'Di ba? As we all remember, ang epinephrine, meron siyang affinity to beta 1, beta 2, and also alpha 1. Specifically, pag sinabing cardiac stimulant, ang receptor na we could relate to it is yung affinity niya to beta 1. Okay? So because of its receptor activity to beta 1 receptor, this could be used as cardiac stimulant. In fact, it is the first line, cardiac stimulant. It could stimulate the heart. Next, first line agent for anaphylactic shock. Okay. Actually, aside from anaphylactic shock, maraming anaphylactic cases or anaphylactic conditions, states, kung saan pwedeng gamitin si epinephrine. So aside sa anaphylactic shock, kindly add also, pwede din gamitin si epinephrine during anaphylaxis. Okay, patients diagnosed with anaphylaxis and also those with anaphylactoid reaction, experiencing anaphylactoid reaction. Again, these are the three anaphylactic states or conditions na pwedeng panggamitan for epinephrine. Now, let's try to understand the three anaphylactic conditions. Meron actually silang differences, merong similarities. So, we'll start with anaphylactic shock. Okay, let's highlight first the word shock. No? Kapag ang isang pasyente is at shock state, experiencing this state of shock, what is caused by shock state is actually due to hypotension. Okay, or hypotensive nga reaction. Okay, or hypotension. Hypotension na lang ito isulat. I repeat, kapag ang isang tao is at shock state, usa sa common or it is actually a general term nga pertain to having hypotension. Usa na siya sa cause. Now, whenever a patient is at shock state, hypotension, pwedeng maraming trigger bakit iyahang nabatian na. Maraming trigger, maraming causes. Sabi dito, anaphylactic nga klase of shock state. So if that is anaphylactic shock, then the cause of that hypotension is allergy. That's the cause. Pag sinabing anaphylaxis, anaphylactic, not anaphylaxis, anaphylactic. Again, kapag ang cause ng shock state ng tao is allergy, we call that anaphylactic shock. And correct, that is life-threatening if that is not given correct intervention or not correctly managed, no? Now, with regards to the application of epinephrine to this condition, sabi dito first line pa nga siya, no, as agent for anaphylactic shock, it is actually has something to do with the hypotension nga effect. Diba sabi natin, kapag ang patient is at shock state, that is due to hypotension. Okay? Now, bakit pwedeng gamitin dyan yung epinephrine to counteract hypotension? So, meron din yung kinalaman sa kanyang receptor affinity. Diba sabi natin may affinity siya sa alpha 1. As we all know, ang alpha 1 receptors, meron yan sila sa blood vessels. Diba? And activation of alpha 1 sa blood vessel will cause vasoconstriction. O, pag may vasoconstriction, ano yung mangyayari sa blood pressure? Of course, it will counteract hypotension, di ba? It will increase blood pressure. Kaya, pwede siyang gamitin at shock state. Okay, kasi napapataas niya yung BP because of its vasoconstricting effect upon activating alpha-1. Okay? So that's for its use sa anaphylactic shock. Now, what about anaphylaxis, anaphylactoid? With regards to the two addition nga shock states, or anaphylactic states rather, meron to silang similarities in terms of symptoms. Ano yung similarities ng dalawa? Ganun din, yung hypotension symptoms being manifested by patient having that reactions, anaphylaxis and anaphylactoid reaction. And also, a patient is also experiencing, yes, shortness of breath or difficulty of breathing. Okay? So, similar na sila nga symptoms manifested by patients having these conditions, anaphylaxis, anaphylactoid reaction. Okay, so no problem with the usage of clinical use ng epinephrine towards counteracting hypotension. So pwede talaga si epinephrine. Kasi nga, meron siyang vasoconstricting effect, iyang i-counteract ang hypotension. Paano naman yung difficulty of breathing? Pwede din, si epinephrine to manage that condition because ano pa yung affinity ni epinephrine? Meron din siyang affinity towards beta-2. Diba? Kung naana siya affinity to activate beta-2, then it could cause or it could counteract bronchospasm. No? So, pwede siya makadilate sa bronchiole. So, bronchodilation yung effect niya. So, counteracting shortness of breath, difficulty of breathing, dapat yun ni siya particularly i-manage during anaphylaxis, anaphylactoid. Kanig yun nga, symptoms ang pinaka-ginalabanan kasi nga, kapag difficulty of breathing na gani na, it is life-threatening already. No, nakakamatay kung dili na anto na siya tagaan og correct nga intervention, prior intervention, no. So good thing we have epinephrine and 'di ba, faster yung onset of action niya knowing it is a natural catecholamine um, um, parenterally administered pa, so mabilis yung action niya sa katawan. So yan yung common symptoms ng dalawa. With regards to differences, meron din silang differences, no? With regards to anaphylaxis, this is associated by an IgE, or this is a condition that is IgE mediated, immunoglobulin mediated siya, whereas yung anaphylactoid reaction, non-IgE mediated, non-immunoglobulin E mediated. So kumbaga, it is induced by drugs. For example, ang anaphylactoid reaction. Yan yung difference ng dalawa. Okay? So if it is induced by drugs, more likely ang reaction na yan, allergic reaction na yan is, we call it anaphylactoid reaction. If induced by drugs. Okay? So yan. Yan yung application again ng epinephrine. Pwede siya for anaphylactic state. Next, sabi dito, it is a local vasoconstrictor. Correct. It is reflective naman sa iyahang affinity towards alpha-1. Diba? So yan, related yan sa iyang affinity to alpha-1. Now, I wanted to highlight also its clinical relevance, no? Or iyahang benefits nga gina-offer sa clinical setting. Ang epinephrine kasi, in the clinical setting, it is combined with another drug. It is combined particularly with lidocaine. I know you have heard about lidocaine when we discuss all about ano yung na-discuss natin sa overview. Sa receptor types, I think, nag-discuss ako. Under type 1 nga receptors, na-mention yung lidocaine. Okay. With regards to lidocaine, it is actually an anesthetic, a local anesthetic specifically. Again, local anesthetic siya. And again, sa clinical setting, gina-combine si epinephrine with lidocaine. So ano yung halimbawa na pinanggagamitan ng combination drug na to? Yung combined na epinephrine with lidocaine, ginagamit ito sila during dental extraction. During dental extraction class. Sa dentista, kung magpaibot kag ngipon, syempre turukan man gyud na imong gums sa area, yung mismong gums kung saan parteng ngipin ang ibton, 'di ba? So injekan man gyud na og anesthesia. Yung anesthesia nga given is actually combined with epinephrine. Okay, so why? Why is it nga ang epinephrine gina-combine man with lidocaine? Why not just give lidocaine alone? Siya raman ang anesthetic. Vasoconstrictor raman si epinephrine. So we actually have two beneficial effects upon combining epinephrine with lidocaine during dental extraction. Number one niyang benefits iyahang gina-provide is to minimize bleeding. Okay? Kaya niyang i-minimize yung bleeding. With epinephrine present, no? Combined with lidocaine, iyang i-minimize. Sorry, nawala. Ayan. Minimize yung bleeding. So, it's reflective to its vasoconstrictor nga effect or vasoconstricting nga effect. Diba? Kung may vasoconstriction, then minimize yung bleeding. Okay, so it's understandable yung first beneficial effect. Yung second beneficial effect, bakit gina-combine si epinephrine with lidocaine is to enhance the local anesthesia effect. Okay? Para ma-enhance natin yung anesthetic effect. Para hindi masakit, no? Yung portion ng ipin kung asan giibtan. Okay? Sige, let's give emphasis on this beneficial effect. Yung pangalawang beneficial effect na na-mention. Bakit kaya with epinephrine na-enhance yung local anesthesia ni lidocaine? Okay, history sa. Okay, regarding sa yung manner no of extraction ng tooth before, ang mga dentist, long time ago pa na siya. Ang mga dentist, ang ilahalag yung gina-administer, ang ginaturok no, sa mismong gums, kung asa dapit ibtan ka og ngipon, anesthesia ra gyud. So lidocaine ra gyud ang ilahang gina parenterally inject no on that gums, okay? Ngayon, na-observe nila nga sa mga pasyente nila biskan nag-inject na sila og anesthesia, masakitan man gihapon ang patient. The reason behind that, according to evidences, studies, ang nangyayari pala upon administering lidocaine alone, upon dental extraction, ang nangyayari, di ba, it is parenterally administered man. Di ba kapag parenterally administered ang isang gamot, isang solution, mataas yung chance na mapupunta siya sa bloodstream. It will be distributed into the bloodstream. Siyempre, atong knowing kung nasa bloodstream ang drug, it will be distributed to the systemic circulation, meaning made-distribute talaga siya sa different parts, no? Different parts, hindi lang doon sa mismong area kung saan ka locally nag-inject, but since parenterally administered siya, it will be distributed to the different parts ng katawan. Okay? So that's the reason pala no behind bakit masakitan gihapon, may kirot pa rin ang ma-feel sa patient despite injecting or administering them lidocaine alone kapag magpaibot og ngipon. So with that problem, with that gap, nasolusyonan na siya with the use of epinephrine. Kasi ano ulit yung epinephrine? It is a local vasoconstrictor. So kapag it is combined with lidocaine pala, ang gagawin niya, pag-inject doon sa gums, kung asa ta mag-ibot og ngipon nga part, i-constrict ni epinephrine ang vessels doon mismo kung asa ta mag-ibot og ngipon, no? Syempre sa gums man gyud na siya i-inject ang solution. So i-constrict niya ang vessel sa portion sa area na yon para ma-accumulate ang local anesthesia. Yung lidocaine nga effect, ma-accumulate doon para enhance ngayon yung anesthetic effect. Okay, so yan yung reason bakit kino-combine na this time ang epinephrine with lidocaine. So ngayon kung magpaibot mong ngipon, kanang gina-inject nga anesthesia actually combination na siya ni epinephrine and lidocaine. Okay, so ito yung mga beneficial effect. Why it is combined with lidocaine, being a vasoconstrictor. Okay, so that's all about epinephrine. And then, before tayo proceed sa norepinephrine, na pa na siya additional nga, wala na may space, no? But dito na lang sa next slide. Aside from these clinical uses ng epinephrine, kindly add also, ang epinephrine is clinically useful for the condition treating glaucoma. Class, if you heard about glaucoma, anong parte ng katawan being affected? Okay, eyes. We actually have a preparation, a specific preparation of epinephrine na being used to treat glaucoma. That's the prodrug of epinephrine. Ang prodrug ng epinephrine, we call it dipivefrin. Dipivefrin. Again, yan yung preparation na ginagamit to treat glaucoma. It's a prodrug of epinephrine. It's not the actual epinephrine, but the prodrug of it, yun yung may benefits towards treating glaucoma. Okay? Now, since we will be mentioning in the preceding slides drugs that treats glaucoma, it would be good if we give overview no on this condition. Ano ba yung sakit na glaucoma? Okay. Ang general knowledge nato is eyes ang being affected. Okay. Now, its pathophysiology, kailangan nating i-understand para may better understanding din sa clinical effect ni epinephrine towards glaucoma. Okay, so ato sang i-understand, give overview lang muna sa glaucoma nga sakit. So yung glaucoma is actually a neurodegenerative disease. Neurodegenerative disease. Okay? So isa siyang neurodegenerative disease and the cause, okay, the cause of this condition, it has something to do with the sensory nerve sa mata na being damaged. So merong sensory nerve sa mata, ga-carry siya og impulses from the eyes towards the brain, yun yung may problema. Okay? So kumbaga there is destruction, damage of, correct, that is optic nerve. Yan yung sensory nerve. Siya yung nagdadala ng sensory impulses from the eyes towards the brain. Okay? Neuron siya. It's a nerve. Okay? So may destruction of it. Bakit? Bakit nade-destroy, damage ngayon yung optic nerve? It has actually something to do with accumulation of aqueous humor, no, sa mata. We actually have a liquid, natural nutritional liquid sa mata. Importante siya to give well nourishment no sa mga structures na nasa mata. Okay? So yung underlying cause pala, bakit nasisira yung optic nerve? Due to accumulation, too much of aqueous humor. Tama ba yung spelling? Okay. Aqueous humor. Yan, again, it's a nutritional source, no? Or nutritional liquid siya sa mata. Okay, so ato sa isulat ang mga important nga information. Again, it's a nutritional liquid or a nutritional source, particularly for mga avascular structure sa mata. Kung mayroon magid kag avascular structure sa mata, yun yung mga parts sa mata nga walang ugat, absence yung vessels. Siyempre, ang ato ang realization ana kung absence ng vessels yung part na yan sa mata, limited siya ngayon ng nutrients. Kaya wa man siya vessels. Remember, sa katawan natin, ang nagdadala ng nutrients sa different cells, tissues, it's the blood. Okay? Saan ba nagdadalo yung blood? Sa vessels, di ba? So kung avascular yung structure na yan, limited yung nare-receive niya na nutrients. But good thing, sa mata, we have this nutritional fluid. Siya ngayon yung magpo-provide ng well-nourishment sa mga avascular structures sa mata. Halimbawa, yung cornea. Yung cornea sa mata, avascular yan. Okay? So kung walang nutrient siyang nare-receive, that will cause damage no sa mata. So yan, importante therefore ang aqueous humor sa mata. Yun nga lang, since importante siya, dapat may tamang control or regulation sa level or amount of aqueous humor in the eye. So there should be proper regulation of it in such a way nga dapat yung inflow ng aqueous humor sa mata should also be equal to the outflow ng aqueous humor sa mata. Ano ba ibig sabihin ng inflow, outflow? Dito ko na lang ilagay sa baba. Class, I will just give overview lang sa pathophysiology para you will understand later the effect, clinical use ng epinephrine for glaucoma. Okay, so ano ba ibig sabihin ng equality ng inflow, outflow of aqueous humor sa mata? Pag sinabing inflow, it has something to do with the synthesis of, tama ba yung spelling? Synthesis ng aqueous humor. Okay? Whereas, ang outflow, it has something to do with the release or excretion. Excretion of aqueous humor. So, kung mayroon kag inflow, yun yung paggawa ng aqueous humor. Then, outflow, yun yung pag-excrete, no? Ng aqueous humor. So, kung mayroon kag dapat equal ang inflow ug outflow, kung ilan yung ginawa na aqueous humor and then na-distribute sa mga avascular structure, kung ilan yun dapat din equal din yung ma-excrete, mare-remove na aqueous humor. Then synthesize ulit, kung ilan ulit yung na-synthesize, ganun din yung i-excrete. Para may tamang regulation sa aqueous humor to avoid accumulation of aqueous humor. Kasi pag nag-accumulate, dumami yung aqueous humor, then that will cause destruction of optic nerve. Okay? Kasi 'di ba yan daw yung underlying cause bakit damage ngayon yung optic nerve. Accumulated yung aqueous humor. So therefore, kung ito yung problema sa glaucoma, mataas or accumulated masyado yung aqueous humor, we could tell nga hindi balanse yung inflow and outflow. That's the reason bakit accumulated mataas no yung level ng aqueous humor. So yung inflow is not balanced no with the outflow. Yan yung problema kaya tumataas yung aqueous humor. Siyempre, kapag mataas yung fluid in one area of the body, halimbawa, yun na nga, sa mata, mataas yung liquid, yung aqueous humor, ang pressure dyan, tataas din. And we actually have a specific term for the pressure na nakakreate sa mata. We call that intraocular pressure. Again, kapag, ito dapat yung realization nyo ha, kapag in that area of the body, mataas yung fluid, ibig sabihin mataas yung pressure dyan. Okay? Specifically, sa mata man ang pinag-uusapan, may tawag sa pressure being created, no? In the eye, we call that intraocular pressure. Okay? Now, with regards to the physiology, no, or anatomical physiology ng mata, para you could understand, no, this information. So halimbawa, ito yung mata, 'di ba? Kung babalikan natin, no, yung anatomy niya. And then this is the optic nerve. Sabi natin, ang optic nerve, siya yung nagdadala ng sensory impulses mula sa mata, ito yung mata, towards the brain. Let's say dito yung brain. Okay? So, paano nadadamage yung optic nerve? By the way, sa anatomical structure ng mata, meron kasi yung anterior portion, meron din posterior portion. May anterior yung nasa harap, yung nasa likod, posterior. Ngayon, sabi natin, kapag hindi balanse yung na-synthesize, halimbawa, ito yung na-synthesize, no, na aqueous humor sa mata, hindi balanse yung inflow at saka yung na-excrete, no? So, more and more aqueous humor ngayon yung mag-accumulate dyan kasi nga hindi balanse, konti lang yung na-excrete. May nasi-synthesize, then konti yung na-excrete. So, mo-accumulate yun ang aqueous humor. So, kapag tumataas yung aqueous humor level, accumulated yung aqueous humor level, ano yung mangyayari sa pressure tumataas, di ba? It will create pressure. In that way, ang nangyayari, because of that pressure, napupush, no, yung anterior portion ng mata due to high aqueous humor fluid, higher pressure, napupush siya, kaya naiipit yung optic nerve. Napupush ba yung mga area from the anterior towards posterior portion. So kung napupush yan palikod, then it will really affect, naiipit ngayon yung optic nerve. And that will cause damage, destruction of optic nerve. Kaya we could tell, no, na any imbalance sa inflow-outflow ng aqueous humor regulation, it could really or highly cause damage later on ng optic nerve, and that will cause glaucoma. And worst about glaucoma, it could affect both eyes. Hindi lang isa, pwede niyang ma-affect both eyes. Yes, and it could cause blindness. Pwedeng mabulag, no, yung tao. Okay, kaya kailangan siyang i-treat. Okay? So with epinephrine, sige, atong ipasok, no, yung mga gamot. So good thing we have drugs. Diri na lang nato isulat sa gilid. So good thing we have drugs. Ang gagawin lang po ng drugs, diba ito yung problem. Ito yung problem sa glaucoma. Bakit tumataas yung aqueous humor or kumbaga accumulated yung aqueous humor ngayon sa mata? May imbalance sa inflow and outflow. So ang gagawin lang ng mga gamot for glaucoma is to restore the balance. The balance between inflow and outflow. So pwedeng ang gamot could reduce the inflow, okay? It could reduce the inflow, or pwede din may mga gamot that could enhance the outflow. Kaya isipin nyo, increase yung, due to the imbalance, increase yung aqueous humor. So paano natin yan i-restore yung balance? I-reduce nato ang pag-synthesize sa aqueous humor. Diba? I-reduce nato para di managhan sa moot. And then, anong gagawin natin sa excretion, sa outflow? Atong i-enhance ang excretion, no, sa outflow. So, yan yung mga mechanism ng gamot for glaucoma. With regards to epinephrine, asa diha ang mechanism no ng epinephrine to treat glaucoma. I will highlight yung second one, yan po yung action ni epinephrine towards treating glaucoma. Ang gagawin niya, it will enhance the outflow. Okay? Paparamihin niya yung pag-excrete no ng aqueous humor sa mata. Therefore, restoring the balance. And therefore, what will happen here to the intraocular pressure, it will decrease, no, lower the intraocular pressure. Okay? Kapag na-restore yung balance. So that's all about epinephrine class. So tapos na tayo sa epinephrine. It's already